Assalamu alaikum. Good morning, everyone, and welcome to our Fast Track review. My name is Rawa Muhsin. I'm a pathologist, and I'll be talking about the causes and the mechanisms underlying obesity. To begin with, obesity is defined as a disease of body weight regulation, and more specifically, a disease of positive energy balance. So to understand this, we need to know what energy balance is. Energy balance refers to the balance between how much energy you take in and how much energy you expend. So how do we take in energy? Well, obviously through food. How do you know how much energy you're taking? Well, you can use online resources to determine how many calories are present in any food item that you take. And nowadays we have AI that you can use to take a picture of the food that you're going to eat and ask it how much calories there are in that meal. So this way you can determine how many calories or energy you're taking in. Now, how do you expend that energy that you take in? Well, there are three main mechanisms. The first mechanism is the basic amount of energy that you need for your heart muscle contractions, for your breathing, for the transmembrane ion gradient. So even if you're not doing any physical activity, you still need that energy for your basic functions. This is about 60% of your energy expenditure. The second one has to do with physical activity. So this would include exercise and movements, and this is about 30%. And then there is a small percentage left for the amount of heat that's generated when you take in food and you digest it. So this is energy intake through food and energy expenditure through these mechanisms. Now, how do you know how much energy you're expending in a day? There are online tools that you can plug in your parameters into, like your age, your weight, your degree of physical activity, and it will tell you how much energy on average you're spending per day. So if you know how much energy you're taking in by counting your calories and how much energy you're expending through these online tools, you can learn to keep a balance between your intake and your output so that there is no dysregulation, there is no excess energy that you're taking in. So this stopped working. Okay. Guys. No. Okay, so now we know that there is energy intake and then there is energy expenditure. Where is this regulated? What center regulates how much energy you're going to take in and how much you are going to spend? That's the arcuate nucleus in the hypothalamus. Well, how does it do that? It's under the control of peptides and hormones that are released from the periphery from the different organs in your body. So here we have adipose tissue throughout the body that releases this hormone, which is called leptin. We have the gastrointestinal tract, which releases a number of hormones like ghrelin. We have polypeptide double gamma. We have cholecystokinin, and obviously insulin from the pancreas. All of these hormones take their signals back to the arcuate nucleus in the hypothalamus, where there are two main types of neurons. We have the pro-opiomelanocortin neuron, which inhibits food intake, so it induces satiety. And we have the agouti-related peptide neuron, which stimulates food intake, or it stimulates hunger. So the different signals from the periphery come to balance this whole mechanism. The main stimulator of appetite from the intestines is ghrelin, or from the stomach, sorry, whereas most of the hormones actually act to inhibit or reduce appetite and induce a state of satiety, including leptin and insulin. So if you keep this picture in mind, you will later understand some of the genetic mechanisms underlying obesity. So now we know that there is energy intake, there is energy expenditure, and there is a center for regulating this. Where do the causes or the factors that lead to obesity come into play? Well, they will influence how much energy you're taking in, how much energy you're expending, and the mechanisms or the functions that are taking place within the hypothalamus, and these include both genetic and environmental factors. So it's not just a simple matter of eating and exercising. Every single aspect of your body mass index, of your adiposity traits, are influenced by your genetics and by the environment in which you live. So matters such as your resting metabolic rate, how much you're willing to do exercise, what type of food you are going to choose, how your body processes that food, all of this actually has a genetic basis and is also influenced by your environment. So starting with the genetic factors, we can classify obesity from a genetic point of view into syndromic and non-syndromic. So obviously, syndromic means that it's part of a larger syndrome where obesity is a prominent feature, and then there are other findings as well. The most common of these syndromes that you may have heard of from pediatrics is Prader-Willi syndrome. This is a disorder of genomic imprinting, and it is characterized by severe obesity from childhood. You can probably not guess the age of this gentleman right here. This is a 19-year-old boy, and his BMI was over 60. These patients have other findings such as hypogonadotropic hypogonadism, developmental delays, and other findings. And you can attribute the obesity, in this case, to the syndrome, to the genetic abnormality that they have. This is another syndromic form of obesity, which is known as Bardet-Biedl. Again, they have characteristic facial features, high arched palate, crowding of teeth, in addition to obesity from childhood. Now, this is syndromic. The non-syndromic forms of obesity, which have a genetic basis, can again be divided into two types. In the monogenic form, we can pinpoint a single gene that is mutated and that leads to severe obesity from childhood. So all of these different mutations involve the pathway involved in appetite regulation in the hypothalamus. The most common of them is the melanocortin-4 receptor. So this is the same picture that I showed you earlier of the hypothalamus, but it's a different illustration. Again, you can see this is the arcuate nucleus, this is the pro-opiomelanocortin neuron, this is the agouti-related peptide neuron. You can see the hormones coming from the periphery and acting on these neurons. So you can imagine, you can have a deficiency in leptin, you can have an abnormality in the leptin receptor, you can have an abnormality in the POMC neuron. All of these can be affected by single gene mutations and lead to severe obesity from childhood. Now, when you understand this mechanism, you can then develop targeted therapies for some of these diseases. So, in fact, a number of these genetic mutations can be targeted with the setmelanotide drug, which is an agonist of the melanocortin-4 receptor to counteract the obesity in these patients. So, syndromic, monogenic forms of obesity, these are rare. The common obesity that you see around you is not due to these mutations. The common obesity is known as polygenic. So you have multiple genes throughout your genome that contribute small amounts to your risk of developing obesity, such that when you receive a patient, you cannot do a single genetic test, identify a single mutation, and say, well, the cause of your obesity is this single gene. That's not how it works. In fact, from adoption, from family, and from twin studies, it's estimated that up to 80% of the different traits that are related to adiposity and body mass index have a heritable basis, have a genetic basis. How many of these do we know so far? Well, a very small percentage, only about 5%. So what about the remaining 70% of genes that contribute to polygenic obesity? We still don't know them. Why? Because they may be rare variants with large effects. It may be due to gene-gene interactions, gene-environment interactions that are not easily picked up on the genetic tests that are routinely done, like genome-wide association studies. So this is only a very small sampling of genes that are involved in polygenic obesity, in the common form of obesity that you see around you. The most important of these genes involved in polygenic obesity is known as the FTO gene, or the fat mass and obesity related gene. This, of all of the genes identified in polygenic obesity, has the strongest impact, and its effect is to increase food intake, or to increase appetite, and to cause a shift in the morphology of adipocytes to white fat, where they store more energy rather than utilize it. So it's not enough to only have a genetic basis or genetic risk for obesity in the common form of obesity if your environment does not also promote it. This was illustrated in a study where individuals who had the same single nucleotide polymorphisms in genes that predispose to an increased risk of obesity actually had different body mass indexes based on when they were born. So those who were born in the early 1900s had a lower risk of developing obesity as compared to those who were born in the later 1900s. Why? Because in the later 1900s, there was more availability of food, there was a more sedentary lifestyle, decreased physical activity, more calorie-rich foods. So this illustrated that simply having those single nucleotide polymorphisms that predispose to obesity is not enough. You need to be in an obesogenic environment. So what are those environmental or acquired factors that contribute to obesity? The most obvious one is dietary intake. So having more access to food, more calorie-rich foods, more sweetened beverages, ultra-processed foods, all of these will, what do they mean? They mean an increased energy intake. So remember the energy balance in the beginning. On the other side of the scale, if you have reduced physical activity, if you have a more sedentary lifestyle, more time spent in front of a TV or in front of a screen, you're going to expend less energy. So you have more energy intake, less energy output. Obviously, this will lead to storage of more energy inside the body. So again, the different types of food have different relations to weight change. Some of them, or most of them, are involved or associated with a positive weight change or a weight gain, and a few are associated with a negative weight change or weight reduction when you use them over a long period of time. So this is for food intake and for exercise and physical activity. What about sleep? It has been demonstrated that shortened nocturnal sleep time, meaning sleeping less at night, doing night shift work, and staying awake are associated with an increased risk of obesity. Why is that? Because when you stay awake, you tend to be sedentary. You're not staying awake to do physical exercise, obviously, and the brain reward centers for food are activated. So when you stay awake, you're more likely to have a higher appetite to eat more. So these will contribute to gaining weight. Smoking cessation has been shown to be associated with a modest weight gain of about 2.5 kg. Why? Because nicotine activates the POMC neuron in the arcuate nucleus of the hypothalamus. So when you remove that stimulus, you are more likely to be hungry and to eat. So because of time shortage, well, I lost a few minutes in the beginning, so I'm going to compensate for that. I'm going to skip some of the issues. You know about the gut microbiome. These are about 100 trillion microorganisms living in your intestines, and they affect many different aspects of your physiology. One thing they do is they modulate the appetite hormones that are released by the gut and that affect the hypothalamus, and this will affect your risk of obesity. This is, again, still in experimental studies. So we'll skip some of these, but there is one important point. Maternal obesity has been associated with an increased risk of obesity in the offspring. And why is that? Well, because of the hypernutritional environment of the uterus in which the fetus lives temporarily, and also through epigenetic modifications. So this is not only genetics, it's epigenetic modifications. Breastfeeding has been shown to have a protective effect. There are many drugs that cause weight gain. There are many diseases that the respected colleagues will discuss. One obvious thing is hypothalamic injury, because we said that's where the appetite regulation center is located. So damage to that center may increase your risk of obesity by causing hyperphagia. So when you take in all that excess energy, it's stored in the adipocytes, so the adipocytes become big or hypertrophic. Not only hypertrophy, they also undergo hyperplasia. Now, which one is more problematic? The hypertrophy of the adipocytes. Because when the adipocytes become hypertrophic, they start to release some inflammatory mediators. This creates a state of chronic low-grade inflammation where there is calling of macrophages into the adipose tissue and a shift in their morphology from M2 to M1 macrophages. This further amplifies the inflammatory response. What is the problem of having this chronic low-grade inflammatory state? Well, it causes a number of problems. First of all, it's associated with insulin resistance, and this leads to a risk of type 2 diabetes. There is also an increased amount of adipogenesis, of producing more adipocytes, like we mentioned, adipocyte hyperplasia. Then there is impaired mitochondrial oxidation of fatty acids, and this leads to their ectopic deposition in the liver and in muscle. And this is what leads to hepatic steatotic disease that will be later talked about in another lecture. And the toxicity from the fatty acids also contributes to insulin resistance and type 2 diabetes. So you can see that the adipocyte hypertrophy and the mechanisms that it leads to are associated with ectopic deposition of lipids in the liver and in the muscle. This inflammatory state also causes damage to the endothelial cells. This increases the risk of atherosclerosis and hypertension. So obesity is not only a matter of weight gain, it's also associated with type 2 diabetes, with cardiovascular risk, and also with hepatic steatotic disease. So why is it important to understand these mechanisms? So that we can develop targeted therapies to these mechanisms. Now imagine if we target some of the pathways involved in adipocyte inflammation, like T helper 2 immunity, like iron handling by the macrophages to prevent their M1 shift, like adaptive immunity. You can develop targeted therapies to assist in the management of obesity. We mentioned the hormones that act on the appetite center in the brain, so you could probably think about using agonists to the satiety hormones, like glucagon-like peptide agonists, to stimulate the satiety center and decrease food intake. Why is all of this important? Why don't we just say, well, eat less and exercise more? Because that's not enough. Why? Because it has been shown that the majority of people who lose weight tend to regain it after a while. And there's a basis for that. It's not just a matter of lack of willpower. It has to do with the body's physiology and the set point for energy balance. When an individual who weighs, let's say, 100 kg loses weight and becomes 80 kg, and you have another individual who has always been 80 kg, these two individuals don't have the same energy balance. The one who lost weight and is now 80 kg is actually in a state of hypometabolism and hyperphagia. The body is trying to compensate for the weight that was lost to regain it. And that's why it's very difficult for them to maintain that lost weight and stay at that weight. That's why you need adjuncts or adjunctive therapies to assist them with the weight loss. So the take-home messages: genetic contributions to obesity. We have syndromic forms, monogenic mutations, these are rare, and then we have polygenic common obesity. Environmental factors, obviously dietary intake, exercise and sedentary lifestyle, sleep deprivation, diseases, and drugs. And these mechanisms lead to an increased intake of energy, which leads to a hypertrophy of the adipocytes, and this creates a low-grade state of inflammation on a chronic basis, and this leads to the complications like insulin resistance, cardiovascular risk, and hepatic steatotic disease. Why is it difficult to maintain a reduced weight? Because the body tries to compensate for that weight loss by causing hyperphagia, meaning an increased appetite for food, and by reducing your metabolism to conserve energy. So they need an extra due diligence throughout their lifetime to maintain that reduced weight. And thank you.